in addition to determining patients' pre-treatment risk by using one of these scoring systems such as Flippy, I do think it's important to look at or determine what we call kind of a risk assessment, and that would be looking at the bulk of their tumor, often how the patient presents, looking at their LDH, looking at their grade. There are different factors that we use to determine patients that are or have high tumor burden, and this is often a kind of modified Gelf criteria. These are criteria that we, again, use to determine whether patients have high bulk. This is often things like large nodes, 3 nodes more than 3 centimeters, 1 node more than 7 centimeters, the presence of circulating tumor cells, splenomegaly, threatened organ function, or symptoms from their disease. Now, looking at those factors, again, if patients have one of these criteria for high tumor burden, then often we do use that to determine treatment. And this is often the decision between watching a patient or initiating often chemotherapy with something like rituximab.
The Gelf criteria is a set of clinical factors that we use to decide whether a patient requires therapy for follicular lymphoma or not. And those include different things like the number of lymph nodes, whether or not the patient has B symptoms, whether they have cytopenias, whether they have a large lymph node mass, and several other things. The British lymphoma criteria includes some of those as well, but it also includes whether a patient is at disease progression within the first 3 months, or whether they have certain organ involvement like kidney involvement or bone involvement. So really what those two things do is that they give us a set of guidelines that help us understand when is the right time to treat someone with follicular lymphoma. The reason that's important is that this is a disease that has a very long natural history. You want to make sure that the patients that are getting treated actually need to be treated, because most of them do very well. So these are tools that help us understand what are the factors that are most likely to cause symptoms in a patient, that are most likely to cause accelerated growth of disease. And that's the reason that we use the Gelf criteria to initiate therapy in patients with follicular lymphoma.
I think that PET scan is a great tool for staging patients and for monitoring response to therapy. PET scans are very, very sensitive at detecting the presence of active follicular lymphoma. In fact, if you look at several studies, they suggest that the PET sensitivity for a patient with active follicular lymphoma is around 97%. So the majority of time, if a patient has active disease and they have follicular lymphoma, it will be picked up on PET. And what I often do when I first see a patient is we'll get a PET scan to determine the stage of their disease. Many times CT scans will miss extranodal disease that can be picked up on PET scan. Large percentage of patients, when you see them in clinic, are initially observed. But many of these patients will eventually develop a reason to initiate treatment. And so we have fairly well-defined parameters or criteria of when to start an asymptomatic patient on therapy. In other words, when does disease get to a point that you should initiate therapy? And this really revolves around 2 main factors, I think. When patients start to develop bulky disease, and that can be defined as splenomegaly, large nodes, meaning 1 node more than 3 centimeters, or 3 nodes more than 7 centimeters, or circulating lymphoma cells, or if they have symptoms from their disease, and that can be from night sweats, can be from fever, weight loss, or pain, or finally, if this disease is pressing on a critical organ. And I like to use the analogy for my patients, like a rock in your shoe, regardless of the size, if it's in the wrong place, you really should take care of it. And many times, or actually probably the most common organ that becomes threatened would be the kidney. There are many nodes in the retroperitoneum that can sometimes press on a ureter. And if that happens, regardless of the size of the node, if there is threatened ureters, I often will initiate therapy. I think that it is important to monitor response to therapy. Clearly, when patients finish induction therapy, they should have imaging. If the PET scan was positive at induction, I think they should get a repeat PET scan to make sure they're in a complete remission. At minimum, they should have a CT scan at the end of induction to determine their response to therapy. I think there's a lot of controversy now about how to monitor these patients after they finish therapy, especially patients that attain a complete remission. In my practice, I often look at CT scans every 6 months, every 3 to 6 months actually in the first year. In the second year, I often go to every 6 months, and after that, if patients remain in remission, it's really kind of up to the patient and the physician. Many times I'll quickly move to annual monitoring in patients with low-grade lymphomas that are asymptomatic and are in remission. So I think, again, this is an area that is evolving. There are some folks that are recommending not doing any surveillance imaging. Many of us are kind of in between that, where we're slowly extending the duration between imaging studies as patients achieve longer and longer remissions.